So thank you. Can I start by saying we don't manipulate people? I just want to put that on the table. But you did kind of manipulate me into coming to speak today by being in the same building as my work, so that was very helpful, and in our terminology we would say that reduced the hassle factor or reduced the friction cost of me attending, so thank you, that was helpful. So I'm going to start with a little bit of a background, I guess, to what behavioural insights is. I'm going to start by acknowledging the traditional owners of the land on which we meet, the Wurundjeri people of the Kulin Nations, and pay my respects to their elders, past and present, and any elders of any other communities who might be here today. Behavioural economics is really the basis of behavioural insights, and behavioural economics is really the drawing together of traditional economics and psychology. Economists were kind of discovering over time that people didn't act and react like the constantly or consistently rational, self-interested, utility-maximising agents that classical economics would suggest. So people aren't always rational, we're not always able to effectively acquire and process all relevant information. We're not that good actually at figuring out and factoring in the future consequences of our decisions, and we're actually quite influenced by people around us in a way that if we were always going to be very rational, we might not be. So essentially we operate really using two kinds of systems in our brain. Obviously this is just a model, but we have two systems in our brain. We have system one, which is really how we go about our daily life. So it's the way we can open doors easily without thinking and pour cereal on our milk and, walk upstairs. It's the 2x2 in terms of maths thinking. System two is what we use when we're being more deliberative in our thinking and we're reflecting and we're analysing. And we certainly have system two and we use it all the time, but system one is really what we use on a kind of 24/7 kind of basis. And the problem is really that the way our minds have developed to enable us to go about our daily lives has also led to some systematic failures, which we call cognitive biases. And biases really evolved along with us, and sometimes for good reasons. So when resources are scarce, as they were for tens of thousands of years in our existence as a species, loss aversion, which is one of the cognitive biases we refer to, it would have been actually quite a good bias to have. So loss aversion says it's the tendency to prefer avoiding losses to acquiring equivalent gains. But if you're an early human, losing a week's supply of food would have been actually much more significant than gaining a week's supply or an extra week's supply of food. So evolution can explain and indeed justify most of the cognitive biases. There's lots of them. You can see, that's just some of the cognitive biases. There's hundreds that are now around the place, and actually they compete sometimes. So it's not like a linear series and we all have the same biases. And actually we don't all show the same biases all of the time. Our past selves can be different actually to our future selves or our present selves. So my current self might be quite happy to fill out a form and be able to make the decision that best suits me and would make best sense for me. But if I filled out that form on a Friday afternoon, I might decide actually I'm just going to choose the option that's at the top of the list because it's easiest. Or actually I might be quite likely not to make a decision at all because I can't be bothered on a Friday afternoon. There's optimism bias, so we tend to be quite optimistic about how we can achieve things, but we also all know that sometimes we can be, have negativism bias and actually not expect things to turn out well. Framing really affects how we make decisions. So if we frame things to people and say you're more likely to make a loss, that actually affects the way we make decisions much more than if we frame it as a gain. And the choice architecture, which kind of underlines a lot of this, shows that how people are presented with different choices and information really does affect our decisions. So as I said before, the ordering of choices on a form makes a big difference. There's been trials which show that if you sign for honesty, a declaration of honesty, at the top of a form, you're more likely to get people filling out the rest of that form accurately than if they sign at the end. I always say people are a bit weird. One of my favourites is the peak end rule, and that holds that people judge an experience, positive or negative, largely based on how they felt at its peak, i.e. at its most intense point, and at its end, so rather than based on the total sum or average of the whole experience. And the effect occurs whether it is a pleasant or unpleasant experience. So I don't know, putting me last, I don't know how that will affect how people think of this whole session. But actually this rule was found through the use of a colonoscopy as the way they tried to figure out whether this rule would hold. And so they randomly divided people into two groups. One underwent a colonoscopy procedure wherein the scope was left in for an extra 3 minutes, but it wasn't moved. This is a while ago, so I think colonoscopies are a little less painful now. So the scope was left in for an extra 3 minutes, but it wasn't moved, so it created a sensation that was uncomfortable but not painful. And the other group underwent a typical colonoscopy procedure. And the researchers found that when asked to retrospectively evaluate their experiences, the patients who underwent the longer procedure rated their experience as less unpleasant than patients who underwent the typical procedure. And moreover, the patients in the prolonged group were far more likely to return for subsequent procedures because there was a less painful end that led them to evaluate the procedure perhaps more positively than those who faced a shorter procedure. But Kahneman, who was the lead researcher on this, made the point, I think, that it's safe to assume that few patients will agree to expose themselves to pain for the sole purpose of improving a future memory. So I'm not suggesting that we go ahead and change scoping practices. Biases don't explain or even produce behaviour, they describe behaviour. And biases and fallacies are labels for a particular type of observed behaviour, often in a particular context that contradicts traditional economics. They're not in general reflective of intelligence, level of education, or even socioeconomic status. In fact, there's a strong correlation actually between confirmation bias, which is the tendency to look for evidence that will confirm your existing beliefs. So there's a strong correlation between confirmation bias and high IQ. So just because you're smart doesn't mean that you can get away from some of these biases. Sorry, room. So they're not flaws, though. It's really important to understand that. And they're broad tendencies rather than fixed traits. So there's lots of different things that affect our behaviour. In the Behavioural Insights unit, we work on behaviour, which we see its observable action. So we know that the way decisions are presented affects our choices, that decision-making is influenced very much by what others are doing, and that despite our best intentions, we don't always follow through with what we intend to do. And factors that shouldn't really make make a difference, I should say, to our decision-making, like our emotions and our habits, actually do affect how we behave. So Behavioural Insights applies all of this, all of what we know about behaviour to public policy service and design. And there's now units like ours that operate across the world in about 200 different jurisdictions, actually. And the units tend to be highly empirical, so the examples I'm going to give you are all based off randomised controlled trials. And we tend to test and trial ideas before we scale them up. And this enables us to understand what works and, importantly, what doesn't work and for whom. So the Behavioural Insights team in the UK was the first Behavioural Insights team that was set up inside a government. And they came up with this framework to describe some of the 4 key concepts in terms of how we can use what we know about behaviour and apply it to service design. These are just 4 of the main concepts, but it does give us a nice framework. So the first one is make it easy. So you'll see they've come up with a mnemonic, so it's easy to understand. So it's EAST, easy to remember. So make it easy. So it's really important that we reduce the hassle factor and the friction costs associated with when we want to incentivise behaviour. On the flip side, if we want to disincentivise behaviour, we can increase the hassle factor or increase the friction costs. It's important, though, to also simplify messages, make it easy to understand. And we've mentioned it already a couple of times this morning or this afternoon, using checklists to break down tasks into chunks can be really useful, and behavioural insights teams use checklists a lot. We also can harness the power of defaults. So that's an opt-in or an opt-out kind of system in the choice architecture. So we know because of the hassle factor, because it kind of gets annoying for people to have to do something to either opt-in or opt-out, when we want people to do something, we set a default that's an opt-out. And when we don't want them to do it, we might make it an opt-in. It's important with opt-outs to understand that they're still choice preserving. So people can still make an active decision to leave whatever that choice is. It just means that we don't have to work a lot harder to get them to opt into something. Make it attractive. So salience is really important here. We're very focused as humans on things that are personalised to us, things that stand out on pages. We're also very attracted to things like rewards and sanctions. They become quite salient to us. Make it social, so we're actually really strongly motivated by what other people are doing around us. So if you want to harness this, you tend to show that most people perform the desired behaviour, and I'll talk a bit more about this later. And encouraging people to make commitment to others. So like anyone who's tried to do a gym program, you know that if your buddy does it too, you're more likely to go. And finally, make it timely. So intervention times are really important. We know that we want to prompt people to take action when they're most receptive to that action. So it might be that a particular time of day or a particular time during a work time is a better way or a better time to implement whatever you're trying to change. And if you help people plan their response to events, that can help as well. So a lot of the time when we're thinking about what interventions do we want people to do, we'll think about, okay, well, when are they already making a life change? So when people are moving house, can be a really good time to encourage them to take up a different energy plan, for example, or if they're getting married, or those kinds of life changes when people are already stopping and reassessing things can be a good time to use these strategies. So I thought I'd just run through, I'm not sure how much time I've got, run through a couple of quick examples of behavioural insights in practice. So you might have heard about this one. It was relatively recent. The Commonwealth Behavioural Insights Unit actually ran this project. And basically it was trying to reduce the overprescription of antibiotics. GPs have been prescribing for acute respiratory infections at a rate 9 times higher than recommended by therapeutic guidelines. And we know that they can overprescribe for lots of different reasons. It could be that in the early stages it can be difficult to tell whether an infection is mild or the start of something more serious, and so GPs might prescribe antibiotics to minimise the risk. We know that illnesses like colds and flus are caused by viruses for which antibiotics don't work, but can cause similar symptoms as to bacterial infections. GPs can be under time pressure to see a large number of patients, and providing a script can be a faster way to complete a consult. And a GP might also perceive refusing to prescribe antibiotics to patients that it could threaten the doctor-patient relationship, which is an important factor, obviously, for GPs. And at the same time, the reasons to avoid prescribing antibiotics aren't always salient or immediately available to GPs. So this trial, which was completed in Australia last year, 4 letters were sent out to GPs and control. So it was a very large trial, which means we can be pretty confident of the outcomes. So basically it was based off research that was done in the UK and the US, but really contextualised to the Australian context, which I think is why we've seen some better results out of this trial than overseas, actually. So it was individualised to GPs rather than to clinics, which was done overseas. And it was sent to the top 30% of prescribers of antibiotics. So GPs received 1 of 4 letters or nothing as the control, and it was sent by the Chief Medical Officer. So the education-only letter contained the usual education messages about antibiotic resistance, and they were also sent to posters to hang up in their clinic. The second intervention was an education with peer comparison letter. So it included the same education information as the education-only letter, but it had like a tagline at the beginning which said, "You are prescribing at a level that's about 80% of your peers, so you're at the top 80% of prescribers," or whatever the number was, between 70 and 100. The third one was a peer comparison with a graph, so including the peer comparison information but showing it in a graph format rather than just words. And the fourth one was peer comparison with delayed prescribing. So it included the peer comparison tagline, but it also provided delayed prescribing materials. So it enabled doctors to have a conversation with their patients and say, "Here's the script, but maybe don't fill it straight away." The letters were sent out in early June, right before winter season, so it was a timely intervention. And the scripts filled was the outcome measure, so not just how many were prescribed, but actually how many got filled. They showed a reduction of 126,000 scripts filled compared to the control group, so a pretty significant reduction based off this intervention. It worked best for the highest prescribers, which is probably unsurprising. You really don't want to be like in that last percentile. And it also worked best in areas of low socioeconomic status. Age or sex of the doctor, though, made no difference. And I think that, so you can see the results there, and quite clearly the peer comparison and the graph was the most successful intervention. And it's probably because it was most salient, so having that graph made it easy to just quickly see where you sat compared to your peers. And, I think in the context of GP, where you really have no way of knowing what the person in the next room is doing to you, doing in the same context, let alone across the country, it was a really effective way of demonstrating where they sat in terms of prescribing. And the effects of peer comparison have been seen in a bunch of different trials in a whole lot of different areas. So this is obviously one in health, but you might be familiar with the letter that was done in the UK that was said 9 out of 10 people pay their tax on time. And it turned out that the 1 out of 10 people then started to pay their tax on time. And they recovered hundreds of millions of pounds more quickly just by sending out a letter that enabled people to understand where they fell and that they were quite different to the rest of the population. A sign hung in a hotel room stating that 75% of guests reuse their towels more than once, increased the amount of towel reuse by 7%. And a US study actually found that first-year college athletes with personalised peer comparison feedback substantially reduced heavy drinking compared to amongst the treatment group compared to the control. And actually the controls saw an increase in heavy drinking over that first-year period. So peer comparison can work across many different areas. Oh, there we go. I had a slide. So here we have a study that was done in the UK on hospital prescription charts. I was interested to see the Victor charts. I haven't seen them before. And in this study, they redesigned the hospital prescription charts. Just default settings were used to make sure that medications were given for the optimal duration. Information boxes that are often incompletely filled in, I should say, have been made more salient to prescribers. Prescribers are primed to more legible prescribing, because doctors' handwriting is fabulous. And a short checklist is used to ensure that prescribers carry out important tasks that are often forgotten, including documenting the type of reaction that someone with an allergy has, or even just the name of the person. And so in this case study, you can see the difference that it made between control and intervention simply by simplifying those prescription charts using behavioural insights techniques. This was a study that my team ran in immunisation. Essentially, we were trying to improve attendance at clinics for HPV. We sent out text messages to parents of children in the appropriate age groups. And the principles that we used were, we made it short and simple, we kept it social, so we talked about how it might affect other people, we provided a real clear cue for action, and we were very clear on what people had to do. And so the trial found that the no-text proportion of children not immunised was at 14%. The most successful intervention, which was make a plan for how you're going to get your kid to school on time, it didn't just win the day in terms of which text message, but it actually pushed the trial cohort into herd immunity. Above 80% for that trial cohort. So now we're looking at how we mainstream this across the state. And finally, so those were some examples of how we can use behavioural insights in healthcare, and there's dozens more, but we also use BI in groups and organisations. I was really interested to hear Ahmed's presentation about Ant-Man and the House Officer and all of those, because we see it, I think, in lots of different organisations where the hierarchy really matters. It's almost like we prepared our slides together, but we didn't. And a lot of the times that will play into some of the biases that we know about, so status quo bias, which is basically let's just do what we've always done, and groupthink, where people tend to confirm each other's thinking, especially when there's a more senior in the room. I was really interested in Gail's presentation around the safety huddle. I think even just framing that in that language of safety creates a different environment for the different people in that group to create a level playing field and a sense of psychological safety amongst those people. And so there's different strategies you can use. Pre-mortems is our favourite, where basically you set up front whenever you're doing a redesign or a new project to actually put yourself in hindsight bias, where you are basically assuming yourself to be a year out from whenever the project's starting, and you say, okay, the project has spectacularly failed, and you try and work backwards to figure out what were those things that made it fail, and then you put in place some risk mitigation strategies. But there's lots of different things that you can do in groups and organisations. The way people sit around tables has an effect. Just sitting next to someone is very different to sitting opposite someone in terms of building psychological safety, making sure that less experienced people in the room speak first so that the first person doesn't bias and prime the discussion. All of those kinds of things. So, I guess the short story is that there are lots of different things that affect how we make decisions, and sometimes they're really quite subtle things in context or environment, or the way things are framed affect how we make decisions, whether as a frontline worker or even as a person going about our day. So get in touch if you want to know more.